All right. Hello, Assalamualaikum, and welcome everyone to our fifth webinar, specialty webinar that is organized by ICRAM UK and Ireland under the Health and Wellbeing team. So today we're having two specialty webinar, and we're going to start with obstetric and gynecology interview webinar. So, before we proceed, I'm going to introduce myself and our speaker today. So, I'm going to start with myself. I'm Fazlin, currently an F1 in Pilgrim Hospital in Boston, United Kingdom, not USA. And our speaker today is Dr. Shafira, who is currently in training in obstetric and gynecology. Dr. Shafira, you can introduce yourself now?
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Shafira. I came to the UK in 2012, whereby I flew from College ISN UEM, where I did my A levels. So I flew to University of Liverpool to do my medicine, and I was there for 5 years. And then I did my F1 and F2 in Trent Deanery. I spent my F1 year in Lincoln, and then I moved to Nottingham for my F2 training. And currently, I'm in Sheffield for my Obs and Gynae training in South Yorkshire, and this will take 7 years. And I've just started in August last year that just passed.
I see. So this is still your first year of core training, is it?
Yes, yeah.
I
So the
see.
memory from the interview is quite fresh.
Congratulations to get accepted in the training program. Before we officially start, if you have any questions, just pop it in the the question, the chat, just behind this next to the screen. And if you have anything, just don't hesitate to ask us anything, and we'll try our best to accommodate to your questions and help you in applying to this program. So let's start our okay, we can start now. Presenting Dr. Shafira with the presentation.
Okay, so I'll just go through a timeline with you guys because this is really, really important. So you need to know what your timeline is so that you can be organized in terms of your preparation and what to expect and things like that, so that you don't miss the deadlines on Oriel as well. So by now you must have had your MSRA assessment. So your invitations to interview will, inshallah, come up on Monday, 20th of January. And then you have your preference first. I don't think that happened to our year because we put our preferences after the interview. But anyway, oh yeah, it's for you guys. It still runs until 12 February, so it should be fine. Yeah, so the interview will be on the 27th until the 31st of January. So it's like a 5-day window, which happened to me as well last year in ATS Stadium. So you choose your interview day based on your readiness, okay? And you have to look at your rota as well, which day is most suitable for you. Like for example, at the time I had a number of on-calls during that week, so I chose to do it on Friday so that I would be totally, inshallah, prepared after all the exhausting on-call shifts. So I chose to do mine on Friday. And I chose to do mine on a Friday morning because I know that I'm mostly productive during the morning time, and I'm a bit more tired in the afternoon. So that's why I chose to do it I chose the slot for Friday morning. So you have to choose all these interview times and dates by yourself, and early birds catch the worms first, right? So make sure you know the deadline, when's the deadline, and when is the best time for you. So basically, Oriel is like one of my favorite tabs when I was doing these application things. I always had my Oriel tab on my laptop to always keep tabs on what's there. Yeah, that's fine. So moving on, with regards to the interview, so 75% will be according to how well you do in your interview, okay? And the remaining 25% is based on your MSRE result. So with regards to the interview, you will have 3 stations. So the first station is on kind of like your portfolio station, whereby they will ask you on your on YONG, on your portfolio, on your extracurricular activities, and your evidence of your involvement in Obs and Gynae, things like that. Don't worry if you haven't done much Obs and Gynae extracurricular activities, because if you still show evidence in your audits in general medicine or surgery, inshallah this will all be counted, because what you want to see is how well you're doing in terms of your extracurricular activities. So don't worry if there's not much under Obs and Gynae. But of course, if you show your commitments in Obs and Gynae now, of course you get points for that as well. But I'll show you in what are the domains involved and the portfolio station. Okay, so yeah, station 1 is about your portfolio. So it involves 50 marks. And then station 2 is on your communications, and it is also 50 marks. Station 3 is on how you prioritize the clinical situations and how you cope with the pressure, that kind of thing. So that is under station 3. It's also 50 marks. And then MSRA carries 50 marks. You have to, there is no minimum score. But basically, to be appointable, you must have scored at least 50% in each of the stations 1, 2, and 3, and a minimum of 100 marks overall. So the whole thing, interview plus MSRA, cumulatively, it's 200 marks in total. The maximum overall score is 200 marks. And to be appointable, you must get at least 50% in each of the station and a minimum of 100 marks overall. So at the end of all these interview and MSRA, you will receive an email on your Oriel, on your Gmail or whatever, saying that, okay, these are your marks for every station. They will give you like a feedback. And then you can also check out your score on MSRA on the Oriel website. So, and then they will also show how many marks in total you gain. And they will also show your ranking as well, among other candidates. If I'm going too fast, just let me know, and please drop your questions in the comment section, and Fazlin will tell me what your questions are. So moving on to the station 1, which is the portfolio station. So the ones that I bold are the ones that are put in bold are the domains in the domains that you must score in. So I told you that it's 50 marks in each station. So actually, each bowl domain, the one that I bowl, each of them carries 10 marks. So 1, 2, 3, 4, 5. So 10. So and there were 2 assessors. So one of them gave me something over 5. Okay, so. And then the other assessor gave me something over 5. So that's how, in the end, I got the marks over 50, if that makes sense. So for example, I got, not for example, in this station, I got 86%, 86 over 100, and that's 43 over 50. So so for example, it's like assessor A gave me 4, and then assessor B gave me 5 for commitment to the specialty, and then so on and so forth, and cumulatively I got 43 over 50. That's how it works. Okay, so I'm just gonna go through the question in each domain, what they ask me. Okay, so for commitment to the specialty, I remember the first question that they asked me was why Obs and Gynae, and so you just have to like say from your heart why you want to do Obs and Gynae. It has to be reasons that are based solely on you, so that you can show your sincerity, why you really want it, and like your passion will just uh, will just shine through from yourself. So what I really said was that I like the mix of medicine and surgery, and I find that this specialty is the perfect combination of both. And I said that I enjoy surgery. I went to the basic practical skills course in London. I like to use I like hands-on experiences. I like surgery and use the dexterity of my hands, um, and I also said that I like to work under adrenaline rush, because in Obs and Gynae, if you like adrenaline, go for Obs and Gynae, because it's the specialty that involves saving 2 lives, and the if if something goes wrong, like the CTG becomes pathological, and when you examine, when you do vaginal examination, you find a cord, and you have to do a C-section immediately, like imminently, and when you examine, you just have to like keep pushing the baby's head so that it doesn't compress the cord, so that the baby doesn't lose his oxygen supply, and you just have to sit on the patient's bed, and just keep pushing the baby's head from the mom's the private part, and then they will push you and the mom on the bed until they reach the theater. So that involves so much adrenaline, and if you like something like that, um you definitely like Obs and Gynae, because and I also said that it involves lots of dynamics. There's no boring day in Obs and Gynae. You get from a woman melodrama episode whereby someone just keeps on complaining about chronic pelvic pain, and then to somebody with antenatal hemorrhage, and then you get somebody with like ectopic pregnancy that requires urgent laparoscopy. So, and then you get somebody with beta HCG of this and that, and a scan review to do. So it's a really interesting specialty. It's not just you sitting in the ward doing boring ward jobs. No, it involves so much movement and so much thinking, and it's there's no boring day in Obs and Gynae. Okay, and then they also asked me what's the specialty training pathway. So you have to be familiar with this picture here, because this is basically what I explained in the interview. So I said that currently I'm in F2, and basic training involves ST1, ST2. By the time I go to ST3, I must have completed my Part 1 MRCOG, which is the exam, and then it involves the intermediate training, ST3 to ST5. And before going to ST6, I must have completed my Part 2 and Part 3 MRCOG, and then ST6 and ST7, blah, blah, blah. So yeah, you have to be familiar with this, because there is a high chance that they will ask the question again. And then so with regards to commitment to the specialty, you get marks for saying that you have attempted the MRCOG Part 1 exam or whatever exam relating to Obs and Gynae, or courses or conferences. You can all just say that, okay? You get points for commitment. What else? And then they also ask me about an experience whereby you had to show your leadership. So I was the vice president in the Obs and Gynae Society in Liverpool, and I did my fair bits of, and I showed my fair bits of leadership there. We ran a regional revision scores for final year students. We ran OSCE stations, OSCE programs, and we ran evening lectures as well. So you have to sell yourself during this station. You have to show why you're the perfect candidate for Obs and Gynae. So just say it all, whatever you've done. And then they also asked me about, I also said that, so that's clubs and societies. So I mentioned as well about when I was the director for a Syria charity program, and that we conducted volunteering projects and like fundraising stuff as well, and we managed to obtain £2,000 at the end of the program. It was a 5-day program, a week's program, and then we did like baking sale and bowling for Syria, things like that, and then we managed to get 2,000 in the end. And then and then you just have to like mention all these charitable causes you do as well. Just sell yourself. And then they also asked me, have you ever been in a difficult situation and how did you overcome it? So basically, whenever you say that you're in a difficult situation, you must also say, to get extra points, you must say how you reflect on it and how you improvise. So in my case, I said that, I was working. I worked in the neurorehabilitation ward because I was in rehabilitation medicine rotation before, and I had this patient who were kind of like addicted to Zopiclone, the sleeping tablet, even though he didn't need it, and he took it like for more than 3 weeks, and obviously he became immune to it already, like it didn't work anymore, and it was only gonna bring more harm than good. So I told my consultant that as per guideline, we had to stop this, and then we just had to say nicely to the patient so that they could understand, give and take, compromise, and I advised on conservative measures. And what I said was, in the end, I decided to do an audit on the use of on the appropriate use or inappropriate use of Zopiclone on the ward. Even though I attempted it, so you just have to say it, even though you might not have completed the audit yet. So that's what I said, because I was in the middle of doing that audit. Even though I didn't finish it, but I said anyway because I was already doing it. So yeah, they want to see how you come out from the difficult situation. They don't want you to just mention it, but they want to see how you reflect on it and how it becomes how it brings good impact to you and the patient safety and the patient care and the ward as a whole. How you change things to become much better. And then they also asked me about quality improvement measures. So with regards to quality improvement measures, you need to be aware that currently people either do audits or people either do QIP. So you need to be aware of the differences between these two, because I got asked this when I did my internal medicine interview, where I went as a backup. I don't know why, but I did go. So I attach here the differences between audit and QI framework. So the consultant who interviewed me also asked me what was involved in the audit cycle. So I said, identifying the problem, standards, then collecting data, analyze the data, implement change, and then re-audit. So they want to see how well you know about audits as well. And then with regards to QI, it doesn't take as much time as an audit, and you don't have to do standards. You can even do like simple projects like how we can make hot drinks available in A&E, and you can do it under QI project. It doesn't have to be under audit cycle. So they will ask you what's the difference between QI and audit, and make sure you know the differences between these two and how the frameworks are under these two. So with regards to audits, so again, sell yourself at this point. So they will ask, so tell me what the audits you've done. And I remember that I was like, I did a number of audits since I was in third year medical school, and I'm pretty proud of each audit I do. And so the challenge is which audit you want to sell first. And you have and when you have a number of audits, make sure you know you know what you can tell from every audit. So for example, if you have done an audit on the use of the management of atrial fibrillation, the use of anticoagulants in atrial fibrillation patients. That's one of the audit I had that I co-authored in. So you have to know what was the conclusion in the audit you do, because they are very interested to know, and they want to know from the station. Because I got a comment saying that I was a bit hesitant when I wanted to share about my audit, and I think because I was a bit like mentally stuck at what I wanted to share with regards to the conclusion of my audit. But basically, make sure you can like tell what are you looking for in that particular audit, and what you achieved, and the conclusion you get from each audit you do. So, and then I also said that we presented we did a poster presentation in the annual British Geriatric Society cardiovascular meeting, and we won first place. We got awarded the best poster in that meeting. So you have to also share with them, so that you did your oral audit oral or poster presentation, and what awards you get from the conferences, because you will get more points when you share what awards you have. And then so I started off with that one because I knew that I would get more marks with that one, because I got prize for that. And then I move on to my second audit, which was also a poster. It was a management of placenta previa, and I presented it in Amsterdam at the British Maternal Fetal Medicine Society meeting, and they all know that conference. That conference is like a really, really good conference, and if someone mentioned that during that interview, they would be very impressed. So please just sell yourself basically. Know your every audit. And then moving on, the fourth domain is on research and teaching experience. They didn't have time to ask me about teaching, but they asked me about research. They asked me why is research important. So I was flicking through. I used onginterview.com for my preparation, and there was this section on like research audit and quality improvement. So I just basically got my answers from there, and tried to be genuine about knowing it. And because I don't like giving textbook script. You have to or overly rehearse answers. So give answers that when you say when you talk in the interview, make sure you know it like genuinely from your heart. It's not like scripted, like you're acting. So they asked me, have you ever been involved? I co-authored in the systematic review on the management of menorrhagia. as a medical student, we presented it as an oral presentation in FIGO, which is a federation of International Federation of Obs and Gynae in Canada, and we found that, and then I mentioned what we found as a conclusion about the ablation, blah blah. So you kind of like have to share, because they want to know. They want to know like whether you know your audit or not, you know your research or not just like the title and then that's it. You present it and then that's it. They want to know how well you know your extracurricular stuff as well. So the last domain is on global score for communication and overall impression. So how you appear in that station. So the comments that I got was that I need to be more assertive, and that I need to come across with confidence. They said that I was very good, but I sold myself short. Well, it was the first station, and I was like, oh my god, about this. Yeah. And obviously, it was only like for 10 minutes, so I was not able to share everything. So you have to choose what you want to say to sell yourself. And yeah, it's very nice of them to say that I'll be a very good trainee as well. So you get feedbacks like this that will be useful for your future. So after the interview, make sure you keep tabs of your incoming emails to be aware of the feedbacks from them. So in total, I got 43 over 50 in this station. And then the second one, oh yeah, this is audit versus research, just for you to be prepared as well for the interview. In case they ask what's audit and what's research, so that you don't get like, you don't get like shocked to receive the answer, to receive the question in the interview. So communication is a bit subjective. I would say this is the most challenging. I find this the most challenging during the interview. What I did was, this is the station that I spent so much time on during my preparation. I had to practice with my best friends, and yeah, just to be well rehearsed with like what kind of scenario could come up. Because anything can come up for under communication. So what you want to see is your communication skills. So that's domain number 1. So this is again over 50, and the first 5 points are the domains that you get marked upon. So they want to see your communication skills, how you introduce yourself when you come in, how polite you are, using the right words, and how you discussed the diagnosis, and how you build rapport with that patient before everything, before you share anything, and if you have to break bad news, how what's the approach you take, so that sort of thing. The communication scenario that I got was a situation whereby this lady, she got misinformed about her diagnosis. She was informed that she got lung cancer, and that they would arrange further tests. But then actually 1 month after that, we produced a letter saying that actually the result is not hers. The result actually belongs to someone else. So actually her investigation that she did before is actually NAD. So that was a very awkward situation, and you just had to jump in there, and then you just had to give your best. So you also need to take so the second domain is ability to take focused, comprehensive history. So mine was about a misdiagnosis of lung cancer. So basically, you just had to ask about risk factors of a really, really good history. Because I thought for communication, I did not have to take a history, but actually you had to. You had to take focused, comprehensive history. And then the management of current situation and arranging treatment. So that's where they check on what what investigation you want to further arrange for this patient. So for that patient, she required that was a chest X-ray at first. Yeah, she needed something like a bronchoscopy or something. So yeah, so you just had. So that's what I mentioned, but of course in layman's term. And she was also a smoker. And the only way I could ascertain that is if I ask is when I asked whether she smoked or not, her risk factors / social history in the comprehensive history part. And yeah, so that's when I asked about smoking cessation, whether she had tried already or not, that kind of thing. And then when she was furious about the misinformed diagnosis, misdiagnosis, she said she wanted to make a complaint. So that's when you talk about pulse. You had to direct her to I had to direct her to the complaints procedure, and you got points for saying pulse. Yeah. And then the last domain was on global assessment, like how you appear in that communication station as a whole. Yeah, and I really find oginterview.com useful. I can't remember how much I paid, but it was I use it for during the whole period. The reason why I like to use it so much is because of the communication part, and for the structured interview one, for the portfolio station as well. For the clinical one, I don't think it's very relevant because it's very obs and gynae-ish. And during the clinical citation, they asked me, something different from oginterview.com. But I found it really useful for the communication one because there were like lots and lots of communication stations that I could practice with my best friend. So it was really useful. I found oginterview.com really useful. So if you want to practice communication, just create scenarios that could possibly come up and just practice. You get points for being empathetic, showing your sympathy, that kind of thing. So yeah, for being professional. So you must get at least 50% in this station to be appointable, to pass. Yeah. Okay, so station 3 is the clinical station. I like this station as well because it's very real. It's not something that it's something that is close to what I experienced during my on calls, because they give us like a piece of paper. On the piece of paper, laminated, there were like 5 different scenarios, and I had to rank them based on how I prioritize them, and and then the top 3 that you rank, they would ask about your management options. So there was a patient. Patient A was a patient who had an abdominal pain, very poor vital signs, right iliac fossa pain. So they asked me like, what's your differential diagnosis? So I said appendicitis. Could be, oh, she's a lady. Have we done pregnancy test? So it could be ectopic pregnancy as well. It could be ruptured cyst, could be ovarian cyst torsion, can be anything under abdominal pain in the right iliac fossa. So yeah, A, B, C, D, E. Always say A, B, C, D, E, okay? But then don't just say A to E. Say what you want to do for A, what you want to do for B, and so on and so forth. And you get points for being detailed, like you want to do group and safe and cross match and things like that, and then you want to do lactate and things like that. So you have to mention it in your A to E, like you want to give fluids and things like that. You have to mention, because you get points for that. And then for this patient, I put her as priority number 1, because she was the most poorly among the other 4. And I said that so I mentioned all my A to E blah blah in details, and then I said that I would also I think that she needs an urgent laparoscopy, and I would call my surgical registrar. So you also get points for asking for senior advice, okay? Because that's the reality. You don't manage everyone you see by yourself. So it's really, it's a nice station for this one. I like this station. I enjoy this station. And then rank 2, I put the patient who had a, oh, yeah, it was this man. He was a bit like delirious, I think. He's an elderly gentleman who was found wandering on along the corridor, and he appeared to be confused, but his vital signs is 0. So I put him as number 2 because he's not as serious as number 1. Um, and I said my A to E approach. What I said in the A to E was I want to do I would check in my notes what his reason for admission. Could he be having a UTI? Could he be having a delirium now because he has a UTI? Number 1. A change in his medication regime, or what else? Did he just have a fall? Any sign of can be the kind of confusion be secondary to a fall or trauma? So mention that you want to take bloods and things like that. Mention that you want to give him fluids and things like that. Mention you want to do urine deep to rule out UTI. Because that's very common for signs of confusion, and old men can also get constipation, and that can cause confusion. So basically, you have to share with the assessor what falls under confusion screening, and then I would also check that if he has a cancer, and this could be a metastasis in the brain. I don't know. And I said that I would also consider doing a CT scan, a CT head if he had a fall. So I said, that's why I said for this confused man. And then number 3 was a patient who was already admitted. He was like crying in pain, and he got like right-sided flank pain. And so I said my differential diagnosis. I said my A to E approach. But I did say that I would send my F1 to go there because I had to attend this patient, A and B. And then I said that I would send my F1 to go to this patient C to give him some analgesia first before we, because he was already on, I don't know, I can't remember the treatment. Oh, he was already on treatment for like urinary stone. So that's something that I could that's something that I could delegate. So they want to see how you cope with pressure. They want to see how you prioritize as well, and they want to see how well you do your A to E, and what you have in your mind whenever you come across a patient like this. So you get points for correctly ranking them. So that's what I got. I ranked them correctly. And then my management options, I think I got marks between 4 or 5. No, I got 4 for my management options. And then you also got marks for global score for prioritization and coping with pressure. So yeah. And then the last domain was they would deduct marks if you manage inappropriately, which they said they got no concerns for that. So yeah. So this is also over 50. And I think I got like 43 over 50 for this station. Yeah, so I really enjoyed this station. And the assessors were like really responding to my answers, and I didn't feel like I was talking to myself. So it was really good because I felt like someone was responding to my answers. Because sometimes in interviews they would just like keep quiet, they would be very, very neutral. But these assessors, they were like really, encouraging whenever I said something. So it was nice. This last slide. I just want to say that in Obs and Gynae, you will have a gynae clinic, and in a gynae clinic, there will be patients who come in with abdominal pain. So if you don't mind dealing with patients who keep on coming for like abdominal pain, and sometimes we don't have answers to that, you can do Obs and Gynae because it's the area whereby whereby people have problems in. They come in with heavy menstrual bleeding. They come in with lots of problems pertaining to the reproductive system, basically. So, I mean, I don't mind that. That's why I'm in this field. And then, if you don't mind sitting on the patient's bed, making sure that the baby's head doesn't come down and compress the prolapsed umbilical cord, and they push you together with the patient on the bed to the theater. If you don't mind the adrenaline, go for it. You're for obs and gynae. And then, and if you like surgery, also go for obs and gynae. I really, really enjoy my theater sessions. I really enjoy, doing closing the uterus, closing the rectus sheath, and learning the layers in the abdomen. It's really fun, and closing the skin as well. And then also, in surgery you get to learn laparoscopy. You get to see, you get to see the anatomy in the abdomen, and it's really different from what you see in textbooks. So it's really nice. And you get to do hysteroscopy as well. So many surgeries involved in obs and gynae, and if you like surgery, go for it. And also, not to forget the happy moments in obs and gynae. I think many people like to do obstetrics because there are more happy moments in obstetrics than gynecology. So you get to be part of, of the birth of babies, and especially if it's like their first baby and they've been working on trying to conceive for so long, and you're just part of it. It's really, really rewarding. It's really rewarding. And when they say thank you to you, they actually really, really mean it. So it's like really nice, and you make so much difference in someone's life. And I the reason why I like obs and gynae is because one of the reasons is because you get that satisfaction, immediate satisfaction after you do something. Like after you attempt this delivery and the baby's born, and you just feel the instant reward. So I feel like in obs and gynae you get that, alhamdulillah, quite often. So yeah, I think that's the end of my presentation. And if you're gonna be sitting for the interview soon, all the best. And any questions?
Thank you very much, Dr. Shafira. So I think thank you very much for your very elaborative description on your tips, and I think your experiences that you shared with us have helped us a lot in giving us how the interview will work. And I think so far we don't have any questions from the viewer. So I have a few questions myself. And I think this is quite the common questions that people will might want to know. How would you say the on-call in ONG be like?
So with regards to on-call, I think this is one of the specialties that you get very, very many on-call sessions. And but the nice thing about obs and gynae is that the on-call is divided into obstetrics and gynecology. So it depends on the hospital as well. Some hospitals, they're small, so they just need one combined obs and gynae on-call SHO. But in big hospitals, they will have a separate obs on-call and also separate gynae on-call SHO. So depending on how big the hospital is, I would say that on-call can be quite stressful, but at the same time, you learn when it's stressful. You learn how to cope with pressure. You learn about managing things, because to me, when I started obs and gynae, it was a very steep learning curve. Until now, there's still so much to learn. But I don't mind busy on calls, because I know that's when I need to learn something, when my knowledge is gradually building up, and that's what matters. At the end of the day, what matters is that I'm progressing through progressing through my knowledge and experience. But at the same time, you need to be aware that you're just not providing service. Because as a trainee, you are not just providing service. They want to see that you have done what's required in the curriculum as well. Like at this moment, I must have done at least open and close abdomen in C-section, even though just one. So which I have done, but
Sure.
I need to be also proactive. Even though I'm busy with on calls, I need to make sure that I have to ask for opportunities to do other things. And thankfully, in Obs and Gynae, they respect trainees' requests. So whenever I say that, whenever I feel like I have so many on calls, you can actually just voice out your concern to your supervisor and say that, can I please have sessions in theatre so I can practice my laparoscopy or hysteroscopy, basically surgeries, gynae surgeries. And then I can also say, can I please have sessions on at the early pregnancy assessment unit so that I know how to manage, you know, beta HCG readings so that I can review scans and know what to look in a scan, how to act upon the scan results, and if I think that I don't have many clinic sessions, I can also voice it out. I can say that, can I please have more antenatal clinics because I want to see booking patients, how to manage small gestational age babies and blah blah. So yes, you will have many on calls, but at the same time, you are not just bound to providing service. You are entitled to clinic sessions, like gynae clinics, antenatal clinics, and you're also entitled to theaters as well. And we also have the 2-week wait cancer clinic. So it's called the Rapid Access Clinic, whereby you see patients who are postmenopausal, who have postmenopausal bleeding, and we know in statistics that the most common cause for postmenopausal bleeding is actually atrophic vaginitis, not endometrial carcinoma. So most of the patients I saw was patients with atrophic vaginitis, really. Nothing worrying on the endometrial thickness. So yeah, you can voice out your concerns whenever you feel like you want to have other opportunities in other areas.
I see. I think that's a very good reminder that we are solely responsible for our training as well, right?
Yes.
And how busy we are, we need to keep our knowledge up to date and skills and everything. Yeah, I think that's a very good reminder. And I have one more question. I've heard since medical school that ONG is one of the most program I mean training or work that you get lawsuit from. So is that just hearsay or is it true that, I mean, do we have to worry about that?
To be honest, of I think I don't know the numbers. I don't know the exact data or the numbers.
Mm-mm.
But so far where I work, I can hear people, who say that they want to, not my patients, but like it's going like, people, when people talk behind you or next to you, you can just hear that, oh, this patient wants to complain, blah blah. Obviously,
Mm.
because it's about their babies, it's about their labor experience, especially when it's gone traumatic,
Yeah.
um so and in obstetrics, sometimes there is a gray area whereby different people will act different ways, and
Mm-mm.
none of them are wrong. Okay,
Mm-mm. Yeah.
so as doctors, we understand why this obstetrician prefers to do that way, and why obstetrician B prefers to do that way, because that's how they're trained, from
Mm-mm.
where they do their training, and none of them is wrong. Like they all do the the management plans correctly. It's just different. and because it's a gray area. And sometimes when patients receive different things, like, oh, during the ward round this morning, this doctor says this, but then tomorrow or this evening, this doctor says something else. So communication is really, really, really important. Like, I cannot emphasize enough how important communication is. Like in Ops and Gynae, we always like do informed consent. Like there's always verbal consent. There's
Mm.
sometimes written consent is also very important. But then when it's a category 1 C-section whereby we need to deliver the baby within 15 minutes, that's fine for not doing written consent, obviously. But
Mm.
yeah, it's really important to document. It's really important to explain to patient why you do this, and if they're happy with it, um, so that at the end of the day, the patient is happy with what you do.
Yeah.
And make sure also to in Ops and Gynae, we also give patients the medications license for that particular condition.
Mm.
So for example, if they come with hyperemesis and there are so many antiemetics in the world, but according to the guideline, this is number one, this is number two, number three. And if you give them the number five one, and 1 year down the line, and they found out about it and they're not happy, they can still write a complaint saying, why did they do this? Why did they choose this antiemetic?
Mm.
So you have to discuss with them if it's not licensed, why you want to prescribe with that particular medication. But if it's licensed, it's fine because it's
Yeah.
licensed. But if it's not licensed, you have to mention to them. So at the end of the day, you have to have good communications. You have to explain why you do this, and document as well.
Mm-mm. Mm-mm. I see. Thank you very much, Dr. Shafira, for very helpful tips. And do you have any take-home messages that you want to share with the viewers? Sorry. Dr. Shafira, can you hear me?
Oh yes. I would say for the interview, I think my take-home message would be for the portfolio station. Number one, really know your stuff. Um, really know what you're talking about. And then for this communication one, just keep practicing, practicing, and practicing different scenario. Um, and then for the clinical prioritization, A to E approach, and um, don't worry too much about it because you do lots of on calls already by now, and what you will see in the clinical prioritization is what you have encountered during your on calls, I would say.
All right.
So yeah, just keep
Oh,
calm and appear confident and assertive, inshallah.
nice. Yes, yes. Assertiveness. Yes, they really like to see you very confident in, yeah, selling yourself and everything. Okay, I think that's all from us for this webinar. And thank you very much, Dr. Shafira, again, for sharing all your tips and your experiences. That was very valuable to us in picturing how we are going to face the interview and everything. So we're going to continue with psychiatry if you would like to join in another link. So thank you very much for joining us today and good luck in your application. Assalamualaikum.
Waalaikumsalam.